Hi there. So my clinical pearl involved some show and tell, so I thought it'd be fun to do a video. And what I want to talk about is things that I've learned in the assessment and management of urinary incontinence. Urinary incontinence is actually a very common problem for women. They don't talk about it that much, and they don't realize that there's things that can be done. And as nurse practitioners, there's actually a lot we can do in the primary care setting, and to know how to assess what options there are to treat and then when to refer out. There's two kinds of incontinence, stress and urge. And I'm not going to go into the other types of incontinence that we're dealing with regard to diabetes or infection. I'm talking about the run-of-the-mill kind. Stress incontinence is when we cough, sneeze, exercise, lift something heavy, and it's all due to poor urethral support. Remember that stress incontinence is a urethral problem. If this is your bladder and this is your urethra, normal stress on the bladder, this urethra shouldn't move. But in people who have stress incontinence, the urethra is hypermobile and can move around. And so anytime there's pressure on the bladder, it's allowing urine to leak through. Stress incontinence is often due to damage to the pelvic floor muscles and ligaments, most commonly from pregnancy and childbirth. So if your woman had 9-pound babies 20 years ago, she's probably coming to see you about stress incontinence. By comparison, urge incontinence is a bladder problem. Urge incontinence is when we get the signal of a full bladder and then the bladder begins to contract prematurely before we get to the bathroom and be able to tell our muscles to relax in order to void. This is a neuromuscular problem between the bladder and the brain. This nerve damage can also happen during pregnancy and childbirth, as well as due to a drop of estrogen in menopause. So the first step when someone says she's having incontinence is to investigate the symptoms and determine, does this represent stress incontinence, urge incontinence, or a mixture of both? So the first questions to ask that are the easiest are, does she leak when she sneezes, exercises, lifts something heavy? Also, does she leak even if she's just recently voided, which might indicate the extent of the problem? The positive responses here are indicative of stress incontinence. And treatment is actually going to depend based upon her goals, how bad the problem is, and what the options are. For example, for some women, they may leak only if they get sick and they have really hard coughing, or maybe only when they go to exercise. And for those women, a pad may be fine, and they're fine with doing that right now. The next step up might be something like a tampon, like the OB Super Tampon. And the OB Super Tampon is shorter than most tampons, and when you insert it into the vagina, it expands horizontally, very wide. And as a result, if you look at that urethra, it forms a brace behind the urethra to keep it from moving. So for some women, putting in a tampon before they have to go do exercise or run, and that takes care of their issue, is they're happy with that. Poise developed a product called Impressa that actually has an applicator like a tampon that has a little more of a hourglass shape, but the same thing to brace that urethra at 2 points. Some people love them, other people find them terribly uncomfortable and don't want to deal with them. Another solution that's out there, and the next step up, is what's called a pessary. Pessaries have been around for centuries, but this is what's called a ring pessary. And it's sort of like a big heavy diaphragm. And what we do is you fold it up sort of like a taco here and insert it into the vagina, and it will open up and form a brace, and it braces that anterior wall of the vagina against the urethra. Pessaries are also used for pelvic organ prolapse, which we're not going to get into here. But the thing about them is that most women find them very comfortable and they don't feel their presence at all. You take it out once a week and put it back in. And they use these for years, 10 years, 20 years, and they're quite happy with them. Yes, I'll answer the question, you do not have intercourse with them in place, but I don't know many women that have stress incontinence at the same time as intercourse. Since we're talking about pessaries though, I'll show you another one. This is called a Gellhorn pessary. Similar concept. This is generally used more for women who have more pronounced prolapse because it really is a stronger brace. Again, it gets folded in half, you can see, placed up into the bladder, and this little piece shows you that it's actually in the right direction is why that's there. The difference with the Gellhorn is that you would put it in for about 3 months and you would have to make an appointment to have it removed. inspect the integrity of the skin, make sure there's no ulcers, and then take it out. But just thought it was a chance to show you what they are in case you see them or hear about them in practice. There's no medications that have been approved for stress incontinence. Duloxetine, which is a SNRI, has been shown, though, to improve symptoms of stress incontinence. It hasn't yet been approved by the FDA for such use, and as a result, you can't prescribe it specifically for that. However, if you have a woman coming in who maybe is dealing with depressive symptoms, or maybe some chronic pain, back pain, or fibromyalgia or something, and stress incontinence, and you're thinking about what medication to give her, Cymbalta might be a good choice for you to try. The last option for stress incontinence is surgery, and surgery can be very successful. Some women who have daily leaking that's not managed by these devices or by tampons, or they just don't want to deal with devices and tampons on a regular basis. There are 2 procedures that are done, and at that point is where you would then certainly have to refer out. But let me go back. Primary care can fit in place pessaries for women. But when she wants to go surgery, you would refer to a urogynecologist. The first procedure is called urethral bulking. This is an outpatient, easy procedure where they insert a scope up the urethra, advance a needle, and then at this junction right below the bladder, they insert a material called microplastique that bulks that area up around and provides some support and helps the urethra do its job. The other procedure that's due is called a TVT, transvaginal sling. Some people call it a sling. It's actually more like a shoestring that is inserted underneath and up and forms a brace for that urethra. That does use a little bit of a mesh material, and I won't get into the whole mesh thing here. It is approved by the FDA. It's not the same thing you see as on the TV shows, but again, it's very successful outpatient surgery, and many women are very happy with that. So let's talk about then comparing stress incontinence to urge incontinence. So remember what I said was that urge was a neuromuscular problem related to the bladder. Accordingly, there is no surgical option for urge incontinence. The bladder should be able to contract when you relax. But with urge incontinence, it wants to contract prematurely, and why it's sometimes referred to as an overactive bladder. So the questions to ask: how long can your patient go between voids? It's normal between 2 to 3 hours to hold your urine. Less than 1, that's a problem. Some patients, more than 4. They may be overextending that bladder, and as a result, that's affected the nerve pathway message of when the bladder can't take it anymore. Secondly, once they get the urge, are they actually able to make it, or do they start leaking prior to actually making it to the bathroom? Do they void completely, or do they find that they void and then they wait a little bit and have a second wave that comes? And if they have that second wave, how much? It's actually normal for 2 to 3 tablespoons of urine to still be in the bladder. If not, we would always be going to the bathroom. But some women think, oh, I'm not emptying my bladder because I always have a little bit more. That's okay. But if they're having a whole nother void almost, then that indicates some more of the problem with the bladder recognizing when it needs to empty. How many times a night is she waking up to void? It's normal for women, older women, to get up at least once. If she gets up, though, is she able to make it, or is she leaking on the way? Is she actually wetting the bed? So here's another great question. How much caffeine or alcohol does she drink? Does she have edema in her feet at the end of the day? Is she on diuretic medication? So let's review treatment options then as they relate to these questions. The first step in treating urge incontinence is, unfortunately, lifestyle changes. But they actually can work. So a helpful tool is to have your patient complete a voiding diary. Pick 2 different 24-hour periods, regular periods that act as average to her. And she records from when she gets up how much she's urinated, how often, when episodes happen, and also what has she been taking in. If she takes these 2 average, and also note any circumstances that happened at the time, like I was sleeping or I was exercising. Diaries like this one actually can be very useful in identifying patterns. For example, my wonderful Coke. Caffeine is a bladder irritant. Your morning coffee may not give you the perkiness that you wanted out of it anymore, but that caffeine can irritate your bladder for up to 10 hours after you had the caffeine. And I'm not saying that you have to quit the caffeine or your patient has to quit the caffeine. It's just to know that it's a trade-off. And so if you really want the extra caffeine in the coffee, know that you're going to wear pads. But if that's more annoying to have to wear the pads, you're going to have to try cutting back to decaf. Or maybe have your morning cup, but then make a second cup decaf. Or maybe with alcohol, rather than have a 7 o'clock cocktail at night, make it a 5 o'clock cocktail so that that's not keeping you up all night. So these things are the types of things that a diary can reveal. One patient we had, it was very obvious that she was only voiding every 5 hours and voiding a large amount of volume. So she had been overextending her bladder, which interfered with her bladder giving the normal signal at the 2 to 3 hour mark. And then when it finally couldn't take it anymore, that's when she was having the urge incontinence. So for her, it might be you're going to have to go to the bathroom even when you don't feel it for a while, every 2 to 3 hours to retrain that muscle. So bladder diaries actually can be a very useful tool in helping to diagnose and come up with an initial treatment plan for urge incontinence. So why the leg edema? At night, if you have lower leg edema and suddenly your legs are up at night, all of that fluid is now draining back into your vascular system, and suddenly people are having to get up 2 or 3 times in the night to go to the bathroom. So it might be a matter of coming home and taking some time to keep your legs up for a while before you go to bed. If you're on a diuretic, it might mean changing the timing of your diuretic so that you find when you get the most response to it. Finally, what I didn't ask of a question is if your patient was diagnosed with sleep apnea. Snoring and sleep apnea cause you to do nighttime diuresis. So really, your patient who's coming complaining about nocturia may need a sleep study. So let's say that those lifestyle changes, you try all of those, they don't help, or let's just say she really loves her caffeine and doesn't want to give it up. So what's our next step? The next step would be medication. If she's postmenopausal, sometimes vaginal estrogen cream might be an easy solution. When the vaginal walls lose that estrogen, they become thinner, and actually the signal can cause the bladder to be, the bladder can be a little more easily irritated from whatever's going on in the vagina. You might see on an exam a loss of rugae and color in the vagina and think, this is hypoestrogenic. And if you add vaginal estrogen cream, it might solve her urge incontinence problem. Now, many women are concerned about hormone replacement therapy. Know that vaginal estrogen cream has been shown to be a localized treatment. It does not go systemically. So what that means is you're not going to get help from hot flashes with vaginal estrogen, but it could help if your patient's having recurrent UTIs, painful intercourse, or urge incontinence. There are 2 classes of pharmaceutical medication for urge incontinence that for overactive bladder. The older anticholinergics, such as oxybutynin, can work, but you may recall those have those side effects that a lot of people can't tolerate, like the dry mouth, dry eyes. There are some newer meds like Mirabetrix that are a little more selective for the bladder that people are having a lot of success with. The side effect or the one adverse risk would be a possible increase in blood pressure that needs to be monitored. But if she has no history of hypertension, might be a very good choice for her. Equally effective if a patient doesn't want to take medication or can't take the medication or can't tolerate the medication is what we call neuromodulation. And neuromodulation is a process which you are going to have to refer out at that point to a urogynecologist. There's a method called PTNS, posterior tibial nerve stimulation. And what they do is take an acupuncture needle and put it at the ankle of the posterior tibial nerve and send a stimulation signal, feels like a little tickle, that stimulates that nerve, which actually goes through the bladder on its way to the brain. The problem with PTNS is you have to do it for 12 weeks in a row, about a half hour a week of treatment. It's great if you're retired, but it is as effective, people say, as medication. Mostly it's a matter that for some people they couldn't commit the time to PTNS. The next step up would be something called Intrastim. Intrastim is actually a pacemaker type device that gets inserted under the skin and stimulates the bladder more directly, and that stays in you. So I hope then, this kind of wraps up my talk, that you understand there's a fair amount you can do for your patients with stress and or urge incontinence. and when to appropriately refer her to a specialist. And I know, but you're thinking, what about Kegels? Why didn't she talk about Kegel exercises? So, my preceptor has found, and I agree, that Kegels tend to be a little bit overrated in these situations. I'd even go further and say it's a perfect example of how the healthcare system often places the problem back on the woman. You need to do more Kegels, we say. But most of the scenarios that I've described in these older women, Kegels is not going to help. And in fact, in some of them, where we're trying to teach her bladder to relax, Kegels can be counterproductive. Moreover, most people teach them incorrectly. They teach them that when they're urinating, stop that stream and hold it. But by doing so, you're teaching your bladder to do the opposite of what you want it to do. You might do it once in order to figure out what muscle you're talking about, but that's not really the exercise. It's better to do it when she's relaxing, watching Netflix or something, and then tighten up that muscle, hold it for 10 seconds, relax it for 10 seconds, and work up to maybe doing it 10 times in a row. There's many other factors here that I've addressed that can also be part of the problem, like uterine fibroids that can press on that bladder, or, as we alluded to, pelvic organ prolapse that can cause some problems. And I also didn't go into the physical exam findings in this video. I really just wanted to give an introduction and hand over a few of the tools that I've picked up for the assessment, initial treatment, and understanding of urinary incontinence and how to do appropriate referrals out to a specialist. If anything I said is blatantly incorrect, please feel free to comment on that. I apologize. And I'm open to further discussion on any of these. My main goal of the video was that we never ever tell a woman that there's nothing that can be done. I had a patient that was told there was nothing that could be done 15 years ago when she was starting to have the problem. Now she had full pelvic organ prolapse, complete urinary incontinence, needed major surgery because she still had it in her head that nothing could be done. There's always something that can be done. She may not choose to do it at that moment, and it depends on the level of discomfort she has in her goals. But she should know that there are options. And it's a great example of shared decision-making where the provider can guide a patient through finding a very personal solution to a very personal problem. And please, don't tell her to do Kegels. Thank you.